I often scan through social media and other YouTube videos to discover what is said about breast cancer surgery, so that I can support or refute it according to the available evidence in medical literature. This, of course, is done in conjunction with my background and personal experience as a breast surgeon. Well, a few days ago, I came across this very interesting comment by a surgeon who underwent breast cancer treatment herself. I thought that what she said was worthy of a video to share the concepts behind her statement with women who might have to decide about surgery. What did she say that inspired this video? Stay tuned to find out. In her video, this other breast surgeon said that having encountered problems after her cancer operation, she wished that as a breast surgeon, she was aware of the collateral damage that breast cancer surgery can give. In light of her comments, I thought I should uncover in this video facts about breast cancer surgery which perhaps are not often openly discussed. Before undergoing surgery, it is absolutely crucial for a patient to understand potential issues she might face so that she can make an informed decision on her choice of surgery. I will therefore be sharing the data on the collateral damage of breast cancer surgery, which every woman undergoing treatment should be aware of. The options for the surgical treatment of breast cancer can be classified into two broad categories: breast conservation treatment or mastectomy. Breast conservation treatment involves breast-conserving surgery, which is usually followed by radiotherapy to the preserved breast. Breast-conserving surgery is also referred to as lumpectomy, wide excision, segmental mastectomy, or partial mastectomy. Regardless of the name attached to it, all these procedures involve the complete removal of the cancer with a rim of uninvolved breast tissue all around it. In contrast, mastectomy is the removal of the breast. If a woman so wishes, she may undergo breast reconstruction after mastectomy. During medical consultations with my patients who have been diagnosed with early-stage breast cancer and are eligible for breast conservation treatment, I always show them a series of studies. I would start with this study, which was published in 2007. This Australian research team led by Dr. Martin concluded that Western Australian breast cancer patients treated with breast-conserving surgery have improved survival outcomes over those treated with mastectomy. Several other studies which were published in the years after also demonstrated better outcomes with breast conservation treatment, which is also known as BCT for short. In this study, it was reported that patients who underwent BCT were found to have a higher breast cancer-specific survival rate compared with those treated with mastectomy alone, or mastectomy with radiation treatment for early-stage invasive ductal carcinoma. Through the years, more studies have been conducted with the same conclusion, such that at the 2025 edition of the St. Gallen International Breast Cancer Conference, an expert panel stated that patients should be advised that breast-conserving surgery and radiation therapy is usually the best treatment option with comparable or superior cancer control results, less morbidity, fewer complications, and favorable patient-reported outcomes. Just to reiterate, there has been data suggesting better survival outcomes with breast conservation treatment since 2007, and it is known that BCT is associated with less morbidity and fewer complications. It can therefore be said that the collateral damage with breast conservation treatment tends to be less. This is one of the reasons I recommend it as the procedure of choice for patients who are eligible. However, women are free to choose otherwise. Thus, it is important that they are provided with the necessary information to make the right decision for themselves. It is my understanding that the breast surgeon who lamented her lack of awareness about collateral damage underwent a mastectomy with implant reconstruction as her primary treatment. Therefore, in this video, I will focus on three main potential issues with mastectomy, especially if followed by implant reconstruction, and share insights about other issues in my other videos. Firstly, there is evidence to show that mastectomy is associated with a higher risk of surgical complications than breast conservation surgery. Mastectomy without reconstruction is associated with a post-operative complication rate of 4.04%, while partial mastectomy, or breast conservation surgery, is associated with a complication rate of 1.74%. Women who undergo standard mastectomy with reconstruction are also subject to a higher complication risk. In this study, 5.5% of women who underwent mastectomy with implant reconstruction experienced early postoperative complications. In comparison, women who undergo immediate reconstruction after nipple-sparing mastectomy may have complication rates of up to 20 to 30%, and the rate of complications requiring further treatment is approximately 10 to 12%. So, in the first instance, women with early-stage breast cancer eligible for breast conservation treatment who choose to undergo mastectomy should be aware that surgical complication rate is higher for mastectomy than for breast conservation treatment. In general, complications for mastectomy with reconstruction is higher than for standard mastectomy alone. We next move on to longer-term outcomes. How do women feel about their bodies after mastectomy with reconstruction? This team of doctors from Memorial Sloan Kettering Cancer Center in New York studied post-treatment satisfaction and quality of life for more than 3,000 women after breast-conserving surgery and compared it with those who underwent mastectomy with implant breast reconstruction. Their conclusion was that breast satisfaction and quality of life scores were higher for breast-conserving surgery compared to mastectomy with implant reconstruction in early-stage invasive breast cancer. Another major issue specific to implant reconstruction is the development of breast implant-associated anaplastic large cell lymphoma. Once diagnosed, this condition is treated mainly with surgery consisting of implant removal and capsulotomy. Some women may require chemotherapy. In summary, women with early-stage breast cancer who are eligible for breast conservation treatment and are considering mastectomy may wish to take note that research data shows that these 3 points of collateral damage may occur. Firstly, mastectomy is associated with higher surgical complication rates. Secondly, mastectomy with reconstruction is associated with poorer breast satisfaction and quality of life scores than breast conservation treatment. Thirdly, for women who undergo implant reconstruction, there is a slight risk of developing breast implant-associated anaplastic large cell lymphoma. The risk of experiencing these issues would be for no proven improvement in survival when compared with breast conservation treatment. Please note that I have covered the evidence for 3 major points of collateral damage, which women who undergo mastectomy with or without reconstruction may encounter. This is by no means exhaustive. If you would like to have more information about other circumstances which constitute collateral damage after breast cancer surgery, kindly comment below so that I can prepare a video which answers your specific questions. Thank you for staying until the end of this video. Please like, share, comment, and subscribe if you have found the information helpful. There are a lot more videos on the subject of breast cancer surgery, which I hope will empower women to make decisions to help them live longer and live more in their survivorship. Do join me there too. Until we come together again, take care.